Hello there, this is Dr. Mintz. I'd like to review a CT of the thorax to illustrate some important aspects of anatomy, particularly with reference to the lobes of the lungs and some of the mediastinal vascular anatomy. So let's start and just take an overall view, an overview of the chest and see what we're going to be looking at here. Go. So if you look now in the right and left hemithorax, you see that there's pleural fluid. And I would categorize it as moderate. It's hard to be specific in a report, but this is moderate. I consider mild when it's a small crescent back here. Moderate to a large amount because you don't see the lungs 100% filled with fluid, or rather you don't see the hemithorax on both sides completely filled with fluid, because that would not be a survivable situation. So look at the pleural fluid and see what it's doing to the lungs. Look at the lungs. Now here you have aerated lung. And you can see changing the windows to lung windows, and that's what these are called, lung windows, demonstrate the vascular branching within the upper lobes, which seem less affected by this pleural fluid. But other parts of the lung look abnormal. How would you characterize that abnormality? Well, first of all, this is lung tissue here, this is lung here, and this is lung there as well. So these areas are not aerated. So you have areas of non-aerated lung on both sides. Just a simple little descriptor to summarize what we're seeing. Why is that? The fluid around the lung has accumulated to such extent that it is compressing the lung, pushing the air out of it, and thereby creating what we call atelectasis, or volume loss. When the lung, let's say we have a lung like this, has fluid collecting along around the base, and it squeezes against that base much more so than the upper lobes very often, and that causes this compression of the involved adjacent portions of the lung that are associated with the pleural fluid, and it squeezes them down, and just as a basic simple mechanical pressure that forces the air out and causes atelectasis. Now here you can see a little tiny spot of air in one of the small bronchi there, but for the most part in here you see a little bit of air in the little bronchioles actually, before they have branched into the finer branches more distally in that part of the lung. So these small bronchioles have enough rigidity in their wall to maintain some integrity and continue to hold air despite the surrounding pressure. So this is atelectasis. You can call it volume loss. I think atelectasis is a more accurate and proper medical term in most cases, although I wouldn't generally fault you for saying volume loss. So what parts of the lung are affected by this compression or compressive atelectasis? Well, here you can see that it's certainly the lower lobes, because you follow this all the way down, and that's the bottommost, inferiormost part of both lungs. Here on the right, still filling a little bit of the posterior costophrenic recess. Posterior costophrenic recess is that little curved, boundaried portion of the right hemithorax where that little recess of the posterior part of the lung is of course shaped kind of like this, and the posterior part of it has a recess of that sort. So that's what fits down in here in the posterior costophrenic recess. This side has more fluid, and so this lower lobe is more, on the left, is more fully atelectatic, more fully collapsed. So those are the lower lobes. Well, on the right, we know we have a middle lobe, and let's see if we can see that. Well, here's the right lower lobe. This should be right middle lobe. Of course, it's going to be more anterior, and in a normal situation, it would be abutting the right margin of the cardiac silhouette. In this case, it's pulled away from it because of this atelectasis. Let's put it on the lung window, or partial in-between window maybe, and see if we can discern some of the anatomy. There we go. Okay, so now here we can kind of see lung and this soft tissue there. So if I go up, when you get to the level of the superior mediastinum, that lobe basically has diminished to a very small amount of lung at that more superior extent, which is what you'd expect in the right middle lobe. So this is right upper lobe, and this is left upper lobe, but you can see that a portion of the upper lobes are collapsed too, are atelectatic, because ordinarily the upper lobe, at least at the apex, goes pretty much all the way to the back, the posterior aspect of the hemithorax on both sides. So there is some atelectasis of the upper lobes, but primarily it's affecting the right lower lobe, right middle lobe, and here it's affecting the left lower lobe, and this would be the lingula of the left upper lobe, and probably some other areas of left upper lobe as well. Let's look at the sagittal images, because the sagittal images are usually very good for seeing the lobar anatomy, because you see the planes of the actual fissures of the lungs. So ordinarily, here on the right side of the chest, and you can tell it's the right side, how? Because the liver's on that side. And if we go over to the other side, you see the spleen. So I'll go back to the right side, and we have a right lower lobe here, and it has its own artery, the right lower lobe pulmonary artery. We have right middle lobe here that looks pretty much like it's just the middle lobe. I don't really see any division to distinguish that from adjacent lung right around here, let's say. So I think that the volume loss we have in the right upper lobe is relatively mild, and it's not really creating a compressive atelectasis. What it's really doing is just impressing upon the right upper lobe in this area, and therefore diminishing the overall volume in the right upper lobe, but not actually creating that atelectatic flattened appearance of the right upper lobe. So we have atelectasis of the right middle lobe, which I would say is complete, and if you follow it out laterally, you'll see that it does dissociate from the right upper lobe with a fissure, or a fissure that divides the right upper lobe from the right middle lobe. And of course, the major fissure, which ordinarily divides the lower lobe from the right middle lobe and right upper lobe, here is a capacious fluid-filled space. So bear in mind that on a lateral view, you ordinarily would see just an oblique fissure going this diameter, this direction on a lateral chest radiograph, and you would know that inferior to that is the right lower lobe, and superior and anterior to that in this area would be the right middle lobe and the right upper lobe. But here, the right upper lobe has been compressed and deflated a little bit here superiorly, and because the right middle lobe has fallen away from its position, which is usually like a triangle here, and has flattened out, that has allowed the right upper lobe to expand more fully down into that region. So, more detail perhaps than you need at this moment, but it's a way of seeing things so that when you see a chest CT or a chest radiograph, you can start imagining, you can see with your mind's eye what might be happening. And atelectasis and pleural fluid are very common things that we see. Now let's take a look at the other side, see what we have there. Okay, what do you think this is? Left upper lobe, left lower lobe. Okay, so you see it in the sagittal. Well, here, remember again that, like on the right side, the major fissure on the left courses obliquely. That's a little bit of a different angle, but it's very similar. And so it's safe to assume that this is the left upper lobe, and this is the left lower lobe. Now, there is no middle lobe on the left. There is something like it, which is the lingula, a component of the left upper lobe. And here's that lingula. So now you can see that the left lower lobe is atelectatic. The lingula of the left upper lobe is atelectatic. But like on the right side, most of the upper lobe, the left upper lobe, is fairly well aerated without any really clearly demonstrated atelectatic portions. So that is a summary of the anatomy of the lobes, and it's a depiction of the typical appearances of atelectasis of the lobes of the lung. Now let's switch gears to the vessels, and we'll look at the vessels of the mediastinum, of which there are two most important arterial vessels, and they are the aorta and the pulmonary artery. Now, most people learn the aorta and the pulmonary artery. They learn the aorta first because everyone knows the aorta because it's a nice little bump on the chest radiograph. And then you kind of have a general vague idea of the pulmonary artery. But the relationship of those two arteries is very important. Everybody understands the aorta. Very few people, or relatively few people, really have a full appreciation of the pulmonary artery and the right and left main pulmonary arteries. So let's start out by saying what we have first is the aorta coming out of the heart, arching up and backwards like this as the aortic arch, and then descending as the descending thoracic aorta, all the way down like that till it gets to the diaphragm, and it goes through a hole, a defect, an opening in the diaphragm called the diaphragmatic hiatus. I'm sorry, the aortic hiatus. The aortic hiatus is the point at which the aorta goes from intrathoracic to intra-abdominal. So here then you see an abdominal aorta. And these little structures here actually are the crura of the diaphragm, the anchoring part of the diaphragm where it inserts into the posterior structures. Okay, so this is the thoracic aorta. You have that idea. Now look closely here at the at the aorta, the ascending aorta, as it comes out of the heart. And it has a big neighbor right anterior to it. That is the pulmonary artery. Now let's go back down, and I want you to see that relative to, let's say, relative to the aorta, the pulmonary artery is kind of at 2 o'clock here. Then it's at about 3 o'clock here. Now it's about 4 o'clock. Now it's almost right behind at about 5 o'clock. And that's a very interesting process. And here it's, well, that's not even the main pulmonary artery there behind it, but it's an interesting process because these two arteries in the embryo are just one artery. And the aorta and main pulmonary artery form from one vessel, that is a round vessel like this, and a septation, a division, occurs between the two, and they form, as a result, two vessels. Now that doesn't happen just arbitrarily. It's not just a slice through this sagittal plane like this. But as you can imagine, in order to create this effect, where they swing around relative to one another, that septation that divided the main artery into aorta and pulmonary artery came in here and then made a division like that. So it's not just a straight division, it had a twist to it. And it's the twist and the dividing of that fetal artery that was destined to be both the aorta and the pulmonary artery. That fetal artery is divided not just like this to create two vessels that go up independently, but it's divided like this, and then as you go up farther, it twisted, the dividing process kind of cleaved through it in this way, so that you get these arteries which change their relationship to one another like that. Okay, so you'll see that in another plane, and I think that'll illustrate it a little more clearly. Let's look back where these two are coming from. Where are they coming from? Well, you should be able to just think pulmonary artery is what? Is it oxygenated blood or deoxygenated blood? And where is it going? Well, it is, of course, deoxygenated blood, and it is going to the lungs. So pulmonary arteries go to the lungs, and that they go there because they are carrying blood that requires oxygenation. So this is the main pulmonary artery, so it should be coming out of the right ventricle. Follow this down. What do we have? The right ventricle. The right ventricle. How do I know that's the right ventricle? Well, first of all, this is right ventricle and this is left ventricle. The right ventricle is a little bit more rightward than the left ventricle. But even more so, it is anterior compared with the left ventricle. The right ventricle is anterior. But they could have called it anterior and posterior ventricles, but I don't think that would have been as appealing or usable in daily terminology. So the left heart is referred to when we talk about the left atrium and left ventricle, and the left ventricle is the primary propelling element that contracts with great force. And because it contracts with such great force to supply the entirety of the body with the exception of the lungs, it has a very thick muscular wall. Now, this is not the thickest example, but you can see that it's clearly thicker than the right ventricle, which is not even discernible as a clear structure. The atria have contractibility, but they have a very thin wall too. So again, if we look through this heart and we say left ventricle, and it's not because the contrast is brighter there, that could depend entirely on how long after the injection we did the imaging. So this is left ventricle, this is interventricular septum, this is right ventricle. Left ventricle has thick muscle, right ventricle does not, and it is more rightward and more anterior. Then you know that these chambers here, these two, correspond to atria. The left atrium goes to the left ventricle, the right atrium goes to the right ventricle. But focusing on the ventricles for our present purposes, take a look and you'll see the right ventricle is going to give rise to what vessel? The aorta or the main pulmonary artery? Well, the right ventricle supplies the whole body. It better have oxygenated blood because it's going out to your brain and kidneys and such. So let's see where that goes. Notice how the vessel arises. Here's the right atrium, or the left atrium going to the left ventricle, and the blood gets pushed out here into the aorta. So here is the aorta going up, up, up to form the aortic arch, giving off the vessels to the arms, the head, and then coursing downward as the descending thoracic aorta to enter the abdomen and then supply all the organs of the abdomen and subsequently the vessels of the lower extremities. So this anatomic relationship, I think, can be very helpful when you're looking at CT studies to get your orientation, to be able to describe things well. So let's look at that again and get this firmly in mind, that you have a left ventricle and you have a right ventricle. The left ventricle gets blood from the left atrium and gives it out the aorta. Comes from the left atrium to the left ventricle to the aorta. The left atrium goes into the left ventricle goes out the aorta. So the aorta and the atrium are kind of forming an angle with the ventricle. So instead of what you might expect, which would be blood comes into the left ventricle, the ventricle contracts and goes out the aorta, the blood comes from the left atrium into the left ventricle, and then when the left ventricle contracts, it shoots it back almost the same way that it came from. So that is the aorta, and if you back up, you'll see it's coming from the left ventricle. Here's the left ventricle, right ventricle, left ventricle. You follow up, and you'll see two things. The left atrium empties into the left ventricle, and the left ventricle empties into the aorta, which then continues superiorly as the thoracic aorta, the aortic arch. Of course, this is the ascending aorta, the aortic arch, and then the descending aorta, all of which are components of the thoracic aorta. Let's take a look now at the main pulmonary artery. And I distinguish the main pulmonary artery in that phraseology because it's important to distinguish it from the right and left main pulmonary arteries. And it's very important in anatomy and in radiologic reporting that your nomenclature be absolutely clear and leaves no question as to specifically what anatomic structure to which you are referring. So, we follow the aorta back. Let's go downward inferiorly in the patient and follow this vessel. This is the main pulmonary artery. Look first at how far anterior it is to the aorta. It's really the front of the mediastinum, the anterior part, so it blends imperceptibly with the right ventricle. You really can't see the valve, the pulmonic valve that separates the right ventricle from the main pulmonary artery, but there is a valve there. So that's the main pulmonary artery, and what it does, and this is what a lot of people don't appreciate, is that it's very simple what it does. It courses up alongside of the aorta like that, has that little twist relative to where the two of them are, and then it simply branches just beneath the aortic arch. And this again is because they arise embryologically from the same tissue, so things are in very close apposition to one another. The aorta and pulmonary artery, and even the pulmonary artery and the overlying aorta, certainly on the left. And in development, there is a right-sided aorta, which becomes atretic. So again, follow this down. Right ventricle. Follow it up. Main pulmonary artery. Main pulmonary artery, aorta. Main pulmonary artery. Follow the main pulmonary artery. What does it do? It branches. It divides in a Y shape. You see that Y? It divides in a Y shape, and it does it right under the aortic arch. This is the aortic arch. You don't see that it's an arch because this is ascending and this is descending. But if we go up higher, you see, sure enough, it's an arch. So let's look at that a little differently in the sagittal plane. See how different things might look there. And let me get that down into view. All right. Well now, here's something I just stumbled upon. This is the heart, I'm pretty sure of that. And something is coursing up out of it, or to it. What might that be? We'll cover that in a moment. But you can see, is it the aorta? No, the aorta comes up a little more anterior than that. Is it the main pulmonary artery? No, because we know that that's very anterior. So let's go through this a little farther. Okay, which is this then? Is this going to be the aorta or the main pulmonary artery? Well, I would bet that it's going to be the aorta, even if I didn't see this little branch going up to the neck, because the main pulmonary artery is generally more anteriorly positioned. Remember, the pulmonary artery, the main pulmonary artery, is anterior to the aorta in this region. So if we go through it further, hopefully we'll see something. Okay, here it is. Here is that proximal main pulmonary artery positioned anterior to the aorta. But notice that it's only down here. Okay, this is a little tricky, but I'm going to hopefully bring it home for you. Here is the thoracic aorta coming out of the left ventricle. Here is the right ventricle giving the main pulmonary artery. The main pulmonary artery arises anterior to the proximal aorta, the ascending aorta. But because of that little twist that is undergone during embryology, they change positions, and the pulmonary artery ends up inferior to the aortic arch. Remember, it divides inferior to, below the aortic arch. Well, we can very clearly say that this is aortic arch. So now you can see the aortic arch and the descending thoracic aorta, and you see what happens is the main pulmonary artery comes out very anteriorly from the right ventricle and then dives back. It dives back and divides beneath, inferior to the aortic arch. Let's see what that division looks like. We don't see it in this plane. We saw it in Lycia on the other. Now if I go off to the right, watch what happens right here. And you see that this vessel right here continues. So let's go back. It's a big vessel. This is a big vessel. In fact, if you look here, it's almost as big as the thoracic aorta. Right here, it does have the same diameter as the thoracic aorta, the main pulmonary artery. And it shouldn't need to have as big a diameter because, of course, it doesn't have nearly as much flow. So let's take a look. Or it's not under that kind of pressure. So here is the right main pulmonary artery branching and going off into the right lung. And here you can see a branch from it. Let's see if you get a little feeling of it there. Okay, there's a branch. There it is branching. We go back. We follow it back to the midline, and we see this is the right main pulmonary artery, and at a point we will find ourselves in the midline, which is where the distal main pulmonary artery is. And if we keep going to the left, then we will see the left main pulmonary artery, because this division, this branching, this Y-shaped branching of the main pulmonary artery occurs immediately inferior to the aortic arch. So if we go over leftward here, you see main pulmonary artery branching. If you look at the aorta, though, you don't see any branching. Any branches here are very small, because this is the descending thoracic aorta, and all it really provides blood flow for are some of the structures of the chest wall along that length. So look at this. This will tie it together. If you can keep these things in mind, it's complicated, it's not intuitive, but you have the right ventricle, which, remember, is more anterior than the left ventricle. That's an important thing to remember. You know that the left ventricle is more leftward, but the right ventricle is more anterior and the left ventricle more posterior. So here we have the right ventricle. It looks a little different because of the phase of the injection. So the densely contrast-enhanced blood is in the aorta, and it hasn't quite yet gotten around through all of the organs and come back to allow the main pulmonary artery to look very, very dense like this, and the aorta to have a more washed out appearance. So on the axial images, I think you have a fairly good idea, I hope, at this time. But this is the tricky part. This is what helps you understand the axial images, that the main pulmonary artery comes out of the right ventricle anteriorly and dives back to branch under the aortic arch. That's the statement that summarizes these relationships most clearly. The main pulmonary artery arises anteriorly, meaning very close to the sternum, from the right ventricle, and then dives back to branch inferior to the aortic arch, where it gives off the right main pulmonary artery and the left main pulmonary artery, which then, of course, branch into the two lungs. Last chance here. Let's try this in a coronal plane, and this should summarize things, I think. All right, here we go. Now this will show you nicely how that embryology is obtained from one vessel here that is divided by a septation, and that septation kind of divides in this kind of manner, kind of like one of those circular stairs, and that's why the aorta, which starts out posterior to the main pulmonary artery, ends up superior and somewhat anterior to it, because the main pulmonary artery, here we are, we've gone anterior. The main pulmonary artery arises from the right ventricle. The right ventricle is very far anterior, as is the very proximal main pulmonary artery. So this is the right ventricular area, and this is the main pulmonary artery arising from it. So if we push backward and look more and more posterior, you see what the main pulmonary artery does is it dives posteriorly. It dives posteriorly, and then it divides beneath the aortic arch. Well, here's the aortic arch. It's arching up and then backwards and over. So if we look at this main pulmonary artery going under it, here you can see it goes off to the right and left. Where? Under the aortic arch. This is part of the aortic arch, as you can see. There it is, the aortic arch, and then you have the descending thoracic aorta, which then goes posteriorly and descends as a descending thoracic aorta, which is a little tortuous, which happens with age, and particularly in patients that are hypertensive. So follow the aorta back, aortic arch, and you look under the aortic arch, you have the branching kind of Y branch of the main pulmonary artery, forming the left main pulmonary artery and the right main pulmonary artery. So if, let's see, if this is the aorta coming up and over like that, this is not going to be a very good demonstration, the main pulmonary artery comes back and then divides like that, divides in both directions, right and left, under the aortic arch. So just remember that, and I think you'll be safe in analyzing which is which. Now this case was selected because it's not just an ordinary normal pulmonary artery. This patient has a big pulmonary artery. In fact, the left main pulmonary artery itself is just about as big here as the aorta. Those left and right main pulmonary arteries are normally quite a bit smaller than the aortic arch, as you can imagine. Instead of the aortic arch, which is supplying almost the whole body, the left main pulmonary artery is just supplying one lung, the left lung. So this is a finding that indicates pulmonary arterial hypertension. Pulmonary arterial hypertension has several causes, but basically it results because something has happened to the lungs, possibly the blood vessels in the lungs, or to the lungs as a whole, and then had subsequent effects on the pulmonary arterial branches that have caused the back pressure and subsequent enlargement of the main pulmonary arteries. And you can get this with COPD, where there's destruction of lung, which then, of course, will leave you fewer and smaller pulmonary arterial branches in the lungs for all of that amount of blood to go through. Why does it have to go through? you can't change the amount of amount of blood that's going through the lungs in a given period of time, because every quart, every liter, whatever, every measurable volume of blood that goes out the aorta to the body, the same amount has got to go through the lungs in that same period of time. Think about it. So right above the branching of the main pulmonary artery, you see that the trachea branches into left and right main stem bronchi. Left and right main stem bronchi. So this is an unusual case of pulmonary arterial hypertension with very large pulmonary arteries. And lastly, for the vasculature, let's see what we remember of the venous structures that supply venous return to the heart. First, you have the inferior vena cava. Let's see if we see that very well here. You always see it to one extent or another. Here's the aorta coming down. This is the right atrium, and it's going to be receiving deoxygenated blood, and that's coming up through the IVC, which actually courses through the liver. There is an intrahepatic portion of the inferior vena cava that courses through the liver and goes right up here into the right atrium. Similarly, there is a superior vena cava right here, which comes down into the right atrium. So you have the inferior vena cava, the IVC goes to the right atrium. Looks a little squiggly here, but that's widely patent. And the SVC goes down to the right atrium, and those are the gutters of the deoxygenated blood from the body, which is accumulating into the right atrium and then passing readily into the right ventricle and out to the lungs for oxygenation. Okay, I think that's enough for now.